Hi, everyone. Pretty full house. We figured we'd go ahead and get started, and I just wanted to have the great pleasure of introducing Dr. Tiffany Traina, who's here from Memorial Sloan Kettering to join us, one of my former mentors when I was there as a fellow, just an amazing clinician, incredible researcher, and here to tell us a bit about the triple-negative breast cancer research she's been doing and the program she's running at Memorial. I'll kind of leave the podium to her and let her get started, but we're so glad she's here.
Thank you. Thanks. Good morning, everyone. Thank you so much for the invitation to come down. I made it down last night right before the skies opened up and the thunder and lightning came, and it was just a nice light show as a welcome to Atlanta. It was such a pleasure getting to work with Jane for a few years. We were so lucky to have her at Memorial, and so thanks for the reunion and coming down to visit. An hour just doesn't seem like enough to talk about the new exciting things going on in triple-negative breast cancer. If we really just talked about standards of care, we'd be done in about 5 minutes because the standards today are really the conventional chemotherapies that we have. So I'll spend a little bit of time just establishing what we know about chemotherapy and potentially optimal regimens for triple-negative breast cancer. And then we'll spend a bit of time talking about subtypes of TNBC and where we have some exciting opportunities moving forward. So please interrupt me also. I want this to be useful, so feel free to ask questions and interrupt. So just to make sure we're using the same nomenclature, triple-negative breast cancer is just simply an IHC definition for the most part, and it's representing a lack of estrogen or progesterone driving this cancer and a lack of HER2 expression or amplification. And you can tell right from the beginning that that's a pretty poor definition because it's more a matter of what this cancer isn't rather than what is driving the underlying disease. And although it just accounts for a small proportion of breast cancer, as you've seen in your clinics, it really does represent a high proportion of breast cancer-related mortality. These are higher risk cancers, even stage-matched for ER-positive or HER2-positive breast cancer. They tend to recur quickly, and they also tend to recur in visceral organs or brain metastases as site of first recurrence. So this is our biggest, one of our big problems today in breast cancer. I want to make sure we just make a point of the overlap between BRCA1 and triple-negative breast cancer. So as you look at the literature, there's a tremendous degree of interchangeability of terms that I want to make sure we're clear we're talking about slightly different populations. TNBC is a definition based on the clinical information that we get from our pathologists. The literature talks a lot about basal-like breast cancer, which is really more of a gene expression profile definition. And then we have this portion of patients that have TNBC that have BRCA1 mutations. And so just try to keep in mind this Venn diagram, that there's a tremendous amount of overlap between these tumor populations and patient populations, but they're not exactly describing the same thing. Okay. As a result of that BRCA association, I think it's important to know NCCN has recommended genetic risk evaluation, not necessarily testing, but sort of skilled clinical genetics consultation for women with triple-negative breast cancer under the age of 60. So that's a bit of a higher bar than we're accustomed to seeing. So if you meet a woman with triple-negative breast cancer, irrespective of family history, up to the age of 60, we would recommend a clinical genetic consultation. And that has obviously all the family implications and screening and surveillance implications, but as you'll hear about from a recent press release, this may also have therapeutic implications for the first time. So in terms of standards of care, you can all look this up from NCCN, and there's a laundry list of chemo agents that we have that are active in breast cancer. I've starred a few favorites that we'll talk about in the context of triple-negative breast cancer, but the paradigm really remains the same of single sequential chemotherapy agents. There really is a lack for compelling data that combination therapy has any impact on overall survival. And we fall back on the usual things that you do just intuitively and naturally as a medical oncologist in practice, is balancing what we know about the drugs that we're considering from phase 3 trials or hopefully predictive biomarkers to help us know what drug might be optimal, to disease-related factors, right? What was the disease-free interval? Where are these sites of disease? How symptomatic is the patient? And then patient-related, which is probably foremost and most critical. What residual neuropathy might she have from her adjuvant therapy, which may lead us towards thinking about a different chemo agent. But this is really the art of medicine. And it wasn't until maybe the past couple of years that we had a few key trials I want to go over that helped us prioritize maybe which chemotherapy we should choose over another in TNBC. So this is just briefly what we'll go over a bit on chemotherapy and then spending time on novel therapies in development. So you're probably already aware of the CLGB study 40502 that Hope Rugo presented. And this was a first-line clinical trial comparing nab-paclitaxel to ixabebilone, right, so microtubule-related agents, to the benchmark control arm of just plain old weekly paclitaxel. And for the overall study populations, this is ER-positive or triple-negative breast cancer, weekly paclitaxel just rises to the top again, right, in terms of efficacy, and it actually is really well tolerated. When you look at the subset of patients that had triple-negative breast cancer on that study, you find the curves really reflect the overall study population. So weekly paclitaxel, again, kind of rises to the top and is a very reasonable first-line treatment option, even for women with metastatic triple-negative breast cancer. Now, the trick is, in the adjuvant setting, much of what I'm talking about is on the metastatic setting today. In the adjuvant setting, because these women have high-risk disease, I know our default is giving our best chemotherapy, and these days, women are getting anthracyclines, taxanes, possibly platinum in the neoadjuvant setting, and now evidence that for women who have neoadjuvant therapy and fail to have a pathologic complete response, if they then get capecitabine for 6 months, that improved overall survival. So a woman who's presenting to you with first-line metastatic triple-negative breast cancer may have already seen 5 chemotherapy agents, potentially. So it's very different than maybe your first-line ER-positive breast cancer that was low risk who's only been on endocrine therapy. All that being said, depending on that disease-free interval and when they last saw their taxane, even with this data, you might feel a little bit uncomfortable, worried that they've already developed some resistance to taxanes. And that has been part of what's driven a bit of enthusiasm about looking at platinums in triple-negative breast cancer. So platinums have been around for decades, even in breast cancer, and we've seen activity, but largely they were replaced by the taxanes in the 90s. Part of that is related to a more appealing toxicity profile, and the activity was somewhat underwhelming. And there's been a resurgence in interest in platinums because of that relationship with BRCA1. So there are triple-negative breast cancers that lack the germline BRCA1 mutation, but still have this pattern of sensitivity to DNA-damaging agents and perhaps issues with homologous recombination. And they've described that as a BRCA-ness to triple-negative breast cancer, even if lacking a BRCA germline mutation. And so because of that, there's interest in looking at DNA-damaging agents in folks with somatic TNBC. There have been several phase 2 studies that have shown high response rates to platinums. There have been some encouraging neoadjuvant trials, but we really didn't have upfront data in the metastatic setting with a head-to-head comparison to taxanes until the TNT study reported out. Many people think that chemosensitivity, that DNA-damaging agent vulnerability, would predict for improvement to any chemotherapy, not just, say, platinum. And so this trial that Andy Tutt and colleagues led looked at upfront taxane versus platinum for women with triple-negative breast cancer in the first-line setting or BRCA-associated breast cancer. And I think this was really data that we needed to see. So for the overall study population, there was no difference in response rates, whether you received a taxane or platinum. Where there was some differential responses were in the small subset of women who had BRCA germline mutations. So this is only about 10% of the whole study population, but for those women who carried a germline mutation, there was definitely a higher response rate with the use of platinum over taxane. And when you look at the PFS curves, so really no difference between the two treatments, irrespective of mutation status, but here, if you are BRCA mutant or wild type, it didn't matter in terms of your taxane response. But if you carry a BRCA mutation and have triple-negative breast cancer, you have a much better PFS with platinum than if you didn't. So we start to see differential responses based on BRCA status in the context of TNBC. Once we got beyond first-line therapy, up until a couple of years ago, really any of those other chemotherapy agents on the NCCN guideline would have been appropriate. We had no evidence that one was any better than another. And so much of our treatment decisions was based on really quality of life and convenience of our regimens and perhaps choosing something that our patients hadn't been previously exposed to. But the Embrace trial really changed that for us. So Eribulin is another microtubule sort of targeted agent, and up against treatment of physician's choice in a large phase 3 study, Eribulin improved overall survival. In a subsequent trial, the 301 study, where it specifically looked at Eribulin versus Capecitabine in earlier lines, we saw that there really wasn't much of a difference. Both of these agents were active. But what was very compelling is in the subset of patients with triple-negative breast cancer, the hazard ratio here is 0.7. It really seemed to favor Eribulin over Capecitabine. And so in practice, as I mentioned before, most of our patients with triple-negative disease in the metastatic setting have previously seen taxane, anthracycline, possibly platinum, maybe now even Capecitabine. I find that outside of a clinical trial, I'm using Eribulin earlier on than I would have previously. Right? Embrace study was for much later lines, around 4th line and later. This 301 trial was 0 to 2 prior chemotherapy agents. And so Eribulin and TNBC has come further up the treatment paradigm when we're looking at standard therapies. But despite all of those agents, taxanes, platinums, Eribulin, as you heard before, overall survival from triple-negative breast cancer is the worst of all of our subtypes, and cytotoxic chemotherapy just isn't enough. We've all probably had that experience in clinic where you can get nice chemo response, but it just isn't durable. We'll see shrinkage and brief improvement, but then really rapid progression again. And so we need to be thinking about what other potential drivers are there for triple-negative breast cancer that we can then target. So I asked one of my pathologists to send me a picture of what triple-negative breast cancer looks like. And he first sent me this one, which was sort of a typical grade 3 sort of TNBC. But then he also sent me these two. And I'm not a pathologist, but they don't look very different to my eye. I'm sorry, they look very different to my eye, yet they're all technically TNBC. And so there's heterogeneity just at the H&E level. And now multiple groups have described that there's molecular differences and molecular subgroups that are quite distinct within TNBC overall. And so our interest in one of these subsets really dates back more than 10 years ago now. We had a pre-medical student with us in one of our breast pathology labs, and he had a panel of about 100 breast cancer primary tumors from women who had surgery at Memorial, and was dabbling in bioinformatics and did some gene expression profiling, and then this unsupervised hierarchical clustering, and found simply that, look, on this side of the heat map, we have our known ER-positive cancers, and on this side, we have our triple-negative cancers. And then there was this subset of triple-negative cancers that were clustering over with the known estrogen receptor-positive tumors. And they thought, well, that was interesting. That was almost 25% of the samples. So they looked into this a little bit further to see what was differentially expressed in these groups, what made these guys here different than the rest of the triple-negative breast cancers over here, and found that the androgen receptor had increased expression in that 25%. So that could have just been unclear that it was a driver of the disease. And so they looked at the protein level and found that not only was there elevated expression, a message, there was also increased protein expression of the androgen receptor on those tumors. And then ultimately what we needed to see is if that was driving cell growth. So they were able to find cell lines that recapitulated that molecular profile that were androgen-driven and triple-negative, and found that if you gave them synthetic androgen, they grew. And if you blocked that with flutamide, an AR antagonist that was used for prostate cancer, you could block that growth. They also did a series of experiments to make sure that the AR signaling wasn't sort of co-opting the estrogen receptor. And so in this cell line, if you gave estrogen, nothing happened. If you gave tamoxifen, if you gave fulvestrant, if you tried to block the estrogen receptor, it made no difference whatsoever. And if you combined both your androgens and your ER blockers, no difference whatsoever. So in the end, they were able to say that this profile in the cell line was truly estrogen independent, but androgen dependent. And so that brings us to about 10 years ago, when we thought, well, this should be a pretty simple concept to test in practice. There were plenty of drugs in prostate cancer, And so we were able to get support to look at bicalutamide, an AR antagonist, in women who had androgen receptor positive triple negative breast cancer. And so we thought that we would be able to do this as a single center, and 25% of the patients that we screened would be AR positive. But we quickly found that we weren't finding 25%. We were finding closer to maybe 12% of patients that we were screening were AR positive by our test and by our definition of AR greater than 10%. So we pretty quickly expanded the study through the TBCRC, and this became a multi-center trial at the sites that you see there. And it was a very simple trial design, a simple single-arm phase 2 study where women with metastatic triple-negative breast cancer, regardless of prior lines of treatment, submitted tumor, whether it was primary or metastatic site, for androgen receptor testing. And it was done at Memorial using whatever our pathologists had been doing, largely for prostate cancer. And at that time, the estrogen receptor bar for what was positive and negative was 10%. So we, for similar convention, said AR greater than 10% would be considered positive. And for those women who had AR positive tumors, they went on to just receive bicalutamide orally, continuous daily dosing. And our primary endpoint was set as clinical benefit rate at 6 months. Because as you may have seen or recall from those curves, progression-free survival, even with chemotherapy, for women with triple-negative breast cancer is about 3 months in the first-line setting. So we thought if you could just keep things quiet for 6 months with a hormonal therapy, even if it was prolonged stable disease, that would be a success. And so this is the consort diagram, and it was somewhat disheartening that we screened more than 400 women to find about 12% that had androgen receptor positive disease that ultimately came on to trial. We had 28 on trial. But the study met its primary endpoint. So the clinical benefit rate was about 20%, and those responses were really prolonged stable disease. The one woman who was on study the longest came off after about 8 years because she developed a new primary cancer that was ER positive, and that required treatment and took her off study. So this was a simple proof of concept trial to say, look, we think that there's something there, but this is still a big problem. Median progression-free survival of 12 weeks is still rather short. And so we wanted to try to figure out why, yes?
You said already, but what's the natural history of these?
So it's a great question. So no one had looked, right? And it just was unclear. And if you now go back and look in the literature retrospectively and stain AR and TNBC, sort of TMAs, and look at folks' experience, it's very controversial. Some series say that just AR positive TNBC has a better natural history, and others have found that it's no better and comparable. And there's some literature in the neoadjuvant setting that actually these tumors are very chemo-refractory. So pathologic complete response rates from AR positive triple negative breast cancer is down around 10%, in contrast to upwards of 50% with, say, an anthracycline taxane-based regimen. So it's really unclear because we didn't have that experience previously. And I think it's still a bit unclear. So this median PFS of 12 weeks just wasn't great. Some people did well, but most progressed rapidly. And so we had collected tumor and wanted to really try to figure out what was unique about this subset and just describe it a bit better. Shortly after our trial reported out, there was a case report in the JCO about this woman who was heavily pretreated and then was found to have chest wall metastasis that stained 100% AR positive, and she seemed to derive benefit for quite some time. So it was encouraging to see and really supported that just proof of concept. So as I said, we had collected tumor on the patients that went on to study and collaborated with Joel Parker at UNC to just try to describe a bit better about what the biology of this subset is. And so the first was just to look at how our trial patients, here represented by the black dots, compared to the TCGA experience. So other groups out of Vanderbilt, for instance, have called this subtype luminal AR. And the thought was that maybe these would have such a luminal profile that they would be clustering here with luminal A or luminal B. But in fact, they overlap consistently with the basal-like profile. So that was a bit interesting, maybe not exactly what we expected. When we looked at the degree of AR expression here, these are our trial participants, it was quite comparable to AR expression in basal-like breast cancer. And I'll point out that AR co-expression in ER-positive breast cancer is far more profound, but the relevance of that is still a little bit unclear. We also know that there's great co-expression with HER2-positive breast cancer, and I'll touch on a little bit later of some ongoing studies looking in these other subsets as well. The degree of AR expression alone was not so predictive of benefit. So you can see there's really a wide range, and the red dots represent our patients who derived clinical benefit at least 6 months. So you can see here, and I'm going to show you in another representation of IHC expression compared to message. There's a relationship here, albeit a weak correlation, and this red dot, low IHC, low message, is our woman who was on treatment for 8 years. So this isn't so perfect as a predictor of who was going to respond to an androgen-directed therapy. We also looked at our patients on study according to Vanderbilt's subtyping of triple-negative breast cancer. And we were a bit surprised to find that, look, we knew our patients were AR positive at the protein level. That was required for eligibility. But their molecular profile was not limited to luminal AR. They actually were across the spectrum of molecular subtypes of TNBC. And those patients who responded, who had stable disease, also were beyond just luminal AR in that molecular profile. So we came away from this saying, okay, proof of concept, the study met its primary endpoint. There's a bit of a signal here, but maybe we're not doing such a great job of picking who is going to benefit just using simple IHC. So there are a tremendous number of drugs in development for prostate cancer that we wanted to then subsequently look into and see if we could do better than what TBCRC11 did. And we were focusing previously here on AR antagonism, but I want to spend some time looking at the left side of the slide in androgen production, which subsequently leads to estrogen production. And I alluded to this before, but AR co-expression in TNBC is a smaller subset, and we'll touch on some later literature, but the range is anywhere from teens to 80%. It's really all over the map, depending on the series you look at and the kind of testing you do. But co-expression of AR and ER is much more profound, and upwards of 80% of ER-positive cancers are also AR-positive. And with HER2-positive breast cancer, again, there's a much higher degree of AR co-expression. So I know it's early, but a little bit of steroid synthesis reminder. When we start with our steroid backbone, CYP17 is an important enzyme to then go on to production of androgens and estrogens. And I don't know if anybody in the room treats prostate cancer, but I'm learning a lot through my prostate cancer colleagues. So the drug abiraterone blocks this CYP17 enzyme. And so that's great if you're trying to lower androgens, but it'll also have a downstream effect of lowering estrogens. A downside to this agent is you also lower cortisol. So as a result, there's a feedback loop that drives hyperaldosterone, and you have problems with blood pressure and electrolytes. And so our prostate cancer colleagues figured out you need to give abiraterone with a low dose of concurrent steroids to abrogate that. But because of this interest in lowering both androgens and estrogens, there was a phase 2 study looking at abiraterone in ER-positive breast cancer. And this was reported out a couple of years ago now. It was a 3-arm study of exemestane versus abiraterone with prednisone versus the combination of abiraterone and exemestane. And in short, it ended up as a negative study. So abiraterone was no better than exemestane. The doublet was no better than exemestane. And so CYP17 inhibition with abiraterone in ER-positive breast cancer kind of fizzled and didn't move forward. However, at the same time that this was going on, I was collaborating with my colleague Hervé Bonifat in France in Unicancer, and we had designed a very similar study as TBCRC11 using abiraterone in AR-positive triple-negative breast cancer that they were able to conduct in Europe. And although this is technically a negative study and didn't meet its primary endpoint, you'll find some interesting similarities. So first off, they had a much higher AR positivity rate than TBCRC11. Here it's 38%, still with that same definition of AR greater than 10%. This is using the same antibody that we used and same methodology, but they were looking at primary tumors exclusively, and so a bit higher AR hit rate. You'll find that the CBR24 is almost spot on at about 20%, and median progression-free survival also right about that 3-month mark. So although technically negative, it was comparable to TBCRC11, and I think also sort of supportive of the idea that there's an AR-driven subtype of TNBC, but that we could do better. And so most recently, we had the results of our enzalutamide study, which was a large global trial looking at a more third-generation AR antagonist that's FDA approved in prostate cancer. We had preclinical information from cell lines very similar to what we had with flutamide and bicalutamide, that the use of enzalutamide could abrogate this androgen-driven breast cancer. And so the study MDV11 that I had the pleasure of presenting to about 2 years ago now was slightly different than TBCRC11. Here, any degree of AR staining was considered positive rather than that 10% cutoff. Patients here had to be screened for CNS metastases based on difficulties with enzalutamide, increasing the risk of seizure potentially, so there was some concern there. Also, given that triple-negative breast cancer tends to spread to the brain, these women all were screened and excluded if there were brain metastases seen. And ample tumor tissue was collected. It was an eligibility requirement because there was a pre-specified endpoint planned to do better biomarker development to select for patients who would respond well to AR-directed therapy. But simply, patients were screened, and if found to be AR positive, were offered enzalutamide daily continuous dosing. The primary endpoint here was also slightly different. It was clinical benefit rate at 16 weeks rather than 24. What we found from TBCRC11 is most folks that made it to 16 weeks also made it to 24 weeks. So this was a bit shorter, but the secondary endpoint of CBR24 was present so that we could compare. So the first thing that we found was comparing the DACO antibody and the Ventana antibody for AR, because there is no standard AR testing out there for breast cancer. Different groups were using different antibodies. We wanted to see if that might be accounting for the heterogeneity in AR positivity that we were seeing. But there was pretty good concordance between DACO and Ventana. And you can see folks are either quite low or negative expressors or high. We found that 80% of tumors had some degree of staining, and about 55% were AR greater than 10%. Another difference with this methodology is that it was optimized in breast tissue as opposed to all the prostate cancer methodology that was being used and just applied to breast tumors. This was specifically sensitive to picking up AR in breast tumors. So that is likely what's accounting for the higher hit rate, but that wouldn't be very useful if we didn't see responses, right? So we'll move on to see what our population looked like. About 165 patients were screened. We defined the evaluable population as those patients who had AR greater than 10% and had a post-baseline assessment. But the overall intention to treat population is about 120 patients. And so that's the largest of any of the other trials. Remember, TBCRC11 was about 28 patients. The unicancer study also similarly in about the 30s. So this was a large series. And when you look at who these patients were, so they tend to be a bit younger. Their median disease-free interval of 2 years is pretty typical of what we see for triple-negative breast cancer. A large majority of them have visceral metastases. And also, most of them have received prior chemotherapy. There's a wide range there as well. And so for the primary endpoint, clinical benefit rate at 16 weeks in the evaluable population, the CBR was 35%. And if you're looking for something comparable to the TBCRC and unicancer trials, CBR24 in AR greater than 10% was about 30% as opposed to 19-20%. I would say that this is the first time we've seen objective RECIST confirmed responses from an androgen-directed therapy. Previous to this, there was just prolonged stabilization of disease. And so these are some obligatory pictures of cancer getting better, effusions drying up, masses shrinking. And most of these responses happened relatively quickly in the first few months and then remained sort of stable over time. So when we looked at progression-free survival for the evaluable population, it was about 14 weeks, so a little bit longer than in the other trials. But when we divided out the intention to treat population by degree of AR staining, you can see a little bit more separation of the curves, AR greater than 10% versus AR less than 10%. But you still have this tremendous drop-off in the beginning. We're not doing a great job predicting who's going to benefit up front just by an AR cut point. And so a lot of background work was done on the tumor collected from all patients screened to try to develop a predictive signature of who would derive benefit from enzalutamide. And then when the intention to treat population was analyzed based on that diagnostic biomarker status, we started to see better segregation of the curves here. So in the overall ITT population, about 50% of patients on study were biomarker positive or androgen driven. Those that were diagnostic positive had a median progression-free survival of 16 weeks versus 8 weeks if they lacked that biomarker expression. And the earlier lines of treatment, not unlike in ER-positive breast cancer where we start with endocrine therapy and then move on to chemo, when treated earlier with this approach and diagnostic positive, the median progression-free survival starts to push out to 40 weeks. Again, one of the big questions here is, number one, what's the natural history of the disease? And this doesn't exactly tell us purely that it's a predictive biomarker because everybody on this study received enzalutamide. Ultimately, we need a randomized trial up against a placebo to see if the biomarker really can predict response to therapy over a standard. In terms of overall survival, median for this study population is about a year. It's really typical of TNBC. And when we divide out OS analysis by that biomarker expression, those that were biomarker positive had a median OS of about 18 months. And when looking at early lines of therapy, the median has not yet been reached. So it may be that these folks are doing very well naturally in the absence of any therapy. There's some separate literature that I'm not showing here of looking at this biomarker in a neoadjuvant trial, absent of enzalutamide, just patients receiving neoadjuvant chemotherapy for triple-negative breast cancer. And there's no difference in biomarker positive or negative. So it seems like the differential is coming in the presence of an AR antagonist. In the neoadjuvant chemotherapy setting, it wasn't predictive of one group doing better than another. So in terms of the safety profile, this is a hormonal agent, much better tolerated than a typical cytotoxic agent like the ones I talked about earlier. And so where are we taking this? So we now have 3 studies that have shown a signal and proof of concept that there's something going on here, and maybe we now have a way of finding about 50% of patients screened that could benefit from this approach. So we have a few different things happening. ENDEAR is a randomized phase 3 trial of enzalutamide in AR biomarker positive triple-negative breast cancer. This has not yet opened, but we hope that we're going to see it open in the next few months. This will be a global trial of more than 700 patients randomized to paclitaxel with enzalutamide, paclitaxel with placebo, or an open-label monotherapy enzalutamide arm. It's very challenging to design a study in this subset because your control arm is chemotherapy. And I don't know that we've ever had this experience in ER-positive breast cancer when, say, tamoxifen had to go up against chemotherapy. Things are a bit different today. So this is going to be a really important, hopefully definitive trial of the role of an AR antagonist in AR-driven TNBC. But there are other interesting avenues to look at. So you are probably already well aware of the importance of CDK4/6 inhibition in ER-positive breast cancer. And in this cell line series looking at what cancers are sensitive to CDK4/6 inhibition, there are those tumors that have a luminal profile. Well, I explained that these AR-driven TNBCs have a luminal profile. And palbociclib, which was the first FDA-approved CDK4/6 inhibitor, acts in such a way to block the cell cycle, effectively kind of freezing cancer cells from this division. And so PALOMA-2 was a large randomized trial that showed the addition of CDK4/6 inhibition to an AI significantly improved progression-free survival. And of all the predictors they've looked at in these randomized trials, both Paloma 2 and Paloma 3, the key predictor of benefit is just being a luminal cancer. So we have a phase 1/2 trial of bicalutamide with palbociclib in AR-positive triple-negative breast cancer. We know this cancer has a luminal profile. It has presence of RB, which is important for CDK4/6 inhibition. The phase 1 portion is complete, and so our phase 2 is about to open. You may be wondering, why did we use bicalutamide? And that was largely driven by drug-drug interactions that we've seen with enzalutamide. So enzalutamide utilizes CYP3A4. We have to be very careful about what we partner that with. So here we elected to go with bicalutamide and palbo. And so this trial is open and accruing in the phase 2 setting. Another agent that's really interesting is VT464. So this is a more directed CYP17 inhibitor. So if you think about it, it's a little bit like combining a newer abiraterone plus an AR antagonist all rolled into one. And the nice thing about its selective target is that it's hitting CYP17 lyase. So we avoid the whole issue with cortisol and needing co-administration with replacement steroids. And preclinically in prostate cancer, VT464 has shown activity in cell lines that are resistant to enzalutamide as well as resistant to abiraterone. So it's looked encouraging. It is in trials and in development for prostate cancer. And so we've had a phase 1 study that just completed and was reported in December by my colleague Aicha Guchau. It's well tolerated. It's a hormonal agent. And the phase 2 that is now accruing actually has 4 cohorts to it. One is AR-positive triple-negative breast cancer. Another is AR-positive triple-negative breast cancer previously exposed to enzalutamide and has progressed. The third cohort is ER-positive breast cancer. And then the fourth is actually male breast cancer, a big, well, not a big, but a small group that we really don't have a whole lot of literature on, but there's a rationale for its use here. So VT464 is still accruing, and it's in the second stage of the phase 2 for all of the arms involved. And then as med-oncs, we ask kind of simple questions. If something looks promising in advanced disease, while we're sorting that out, as long as it appears safe, we start to move it up. And so we have an adjuvant study of a year of enzalutamide in women with early stage triple-negative breast cancer, stage 1 through 3, who have AR-positive disease. And this has been accruing well, and there is the option to extend to a second year of adjuvant therapy at the end of that first year if patients are tolerating it. And we actually have our first patient about to hit the 1-year mark without difficulty, so keep an eye out for that. And as I mentioned before, there's a rationale for looking at AR as a target outside of triple-negative breast cancer because there's greater co-expression in ER-positive and HER2-positive disease. So the exemestane plus minus enzalutamide trial is fully accrued, and we expect that's going to report out very soon. There are other agents, novel agents in development being explored, TAC700 and CR1447, looking again in ER-positive or AR-positive TNBC. And the enzalutamide plus Traz study also has accrued, and we hope to have results shortly. So I hope at least to take away from this that AR looks like it has a place in at least a subset of TNBC, and I encourage you to keep an eye out for these trials and try to support them if possible. I wish I could tell you that there's a standard way to screen for this. There isn't. There's no accepted universal AR-IHC for breast cancer. And what we have found is such heterogeneity in the testing that I would encourage, if you have access to a trial nearby, to think about doing your screening through the trial, because now many of those studies are using the more optimized IHC methodology from the enzalutamide study, where you actually have a better chance of finding the AR-positive tumors there. So in our last sort of 15 minutes, I want to touch on other novel targeted therapies in TNBC. And this is a bit hot off the presses. So we've been talking about PARP inhibitors for years, right, with originally, but there are multiple agents that have shown encouraging activity, particularly in BRCA germline associated, BRCA mutation associated breast cancer. Ultimately, what we've needed are phase 3 trials to show us if PARP inhibition is any better than chemotherapy alone. And so several agents have ongoing trials that follow this pattern of a BRCA mutation-associated breast cancer having previously received anthracycline or taxane randomized to that PARP inhibitor versus treatment of physician's choice. And the first of these has reported out in a press release. I feel like we've had 3 big press releases in the past 10 days. So the Olympiad study was comparing olaparib to treatment of physician's choice for BRCA-associated breast cancer. And what we know so far is that this is a positive study in terms of progression-free survival. Don't know how positive, don't know anything more than that, but I'm hoping that we'll see this in the coming months, maybe at ASCO. So this may really change the way you start to approach a woman diagnosed with metastatic triple-negative breast cancer, because I already start to think, okay, triple-negative breast cancer, what's the AR status? Because I may be doing something different for those folks first, second line. Now I really need to know what's their BRCA status, because depending on what these data actually look like, if it's quite compelling, BRCA positive TNBC might go to simple oral olaparib in the first line setting. The other thing that we'll have to think about is these patients did not purely have just triple negative breast cancer. It was BRCA associated breast cancer, including ER positive disease. So what will that mean for who we send for genetic testing if there's really a differential benefit to PARP inhibition over chemo? I don't know. I think we just need to wait and see the data, hopefully in the next couple of months, to understand what was the population in this trial and how that might change practice. There's also a study in the works, not yet open, but trying to answer the question of whether there's benefit to PARP inhibition in folks who have other germline mutations, not just BRCA1 or 2, but there are clearly other less prevalent mutations that predispose to breast cancer, and will they have the same benefit from PARP inhibition? And also, what about somatic mutations in those genes, just in the tumor? Will that confer sensitivity to PARP inhibition that might be any better than chemotherapy? So Nadine Tung out of Boston is leading this. This will definitely be a multi-center study across the country, so keep an eye out for that one. I don't know that that has a fancy name to it yet. So the next class of drugs that we're looking at in triple-negative breast cancer are antibody-drug conjugates. And one that is furthest along is Immu-132. This was just also presented at San Antonio in December. So TROP2 is an interesting marker. It's there on almost all triple-negative breast cancers. So for this study, you didn't even need pre-screening for TROP2 expression. It was assumed that it was likely to be there if you had an advanced triple-negative breast cancer. And it is something that is lost in development. So there really is minimal, if any, expression of TROP2 on normal mature cells, and seems to be there more exclusively in epithelial tumor cells. So Immu-132 is an antibody to TROP2 conjugated with the metabolite of irinotecan. And phase 1 studies have been really encouraging, so the dose has been determined, and within the setting of a subset of patients with triple-negative breast cancer, heavily pretreated. I think, where do I have that up here? It was a median of 5 prior regimens. This waterfall plot is really encouraging for response. So essentially, this is a chemotherapy, but much less diarrhea than what you would expect with irinotecan, really able to deliver it directly to the TNBC, and a median progression-free survival of almost 6 months. So this is in a phase 3 trial right now, and something to keep an eye out for, Immu-132. And there are several other antibody-drug conjugates being tested in triple-negative breast cancer with varying targets much earlier in development. I'm not sure if you have any of these studies going on here, but a class and a mechanism that is compelling. And so finally, I want to touch on the idea of tumor genomic profiling. So almost every place has their own homegrown tumor genomic profiling assay, or we have things like Foundation Medicine. We're trying to look at a mutation profile in a tumor to help predict, sort of classify that tumor, and help potentially predict benefit from a particular targeted therapy in development. So we've been doing this at Memorial with our homegrown test of almost 500 genes, almost 3 years now. And just in terms of breast cancer cases sequenced, it's just been really taking off. I have to say that most of the actionable mutations we're finding more in ER-positive breast cancer and less so in triple-negative breast cancer. But it doesn't stop us from still looking. P53 mutations are incredibly common in TNBC, and we don't have a way to target that just yet. But the hope is that we'll find drivers here that might allow us access to interesting trials early in development. There's a host of potential targeted agents, and I don't think that we can say any one is better than the other right now, but I think that a clinical trial in general for a woman with metastatic triple-negative breast cancer is reasonable even in the very first-line setting, because our traditional cytotoxic chemotherapy just hasn't been enough for them. And then lastly, I'll touch on immunotherapy. I mean, you must be under a rock if you don't hear about immunotherapy in the lay press or your patients come asking for it already. And there's a rationale for why immunotherapy might be of particular use in triple-negative breast cancer. I mean, there's this classic slide that's gone around showing what the mutational burden is of different cancers, and the higher the mutational burden, the more likely we are to see benefit from immunotherapy, right? The melanomas and bladder cancer and lung. Breast does not have a high mutational load. However, triple-negative breast cancer, of all breast cancers, does seem to have a little bit higher than, say, our ER-positive breast cancers. The presence of TILs in tumors may be an encouraging sign of a role for immuno-oncology. Yes, there's high PD-L1 expression, but it's unclear if you need PD-L1 expression in breast cancer to derive benefit from these PD-L1 or PD-1 targeted agents. So I think what we've seen that's compelling, and I just chose the keynote trials here, but we see this with Pembro, you see this in the atezolizumab data. Response rates themselves are in the teens, right? So they're not super high in terms of traditional RECIST response rates, but there are these long tails. There are some patients who respond and have a very durable, long benefit from these agents. And you can see it here. You see it in the PFS curves where there's a pretty quick drop-off, a median PFS of 2 months, yet you've got this tail of some people really deriving benefit for a while. And I think what we're charged to figure out is who's in the tail, and can we understand who is best going to derive benefit from these therapies. We also don't know whether we should be using them as monotherapy or in combination with chemotherapy. This study by Sylvia Adams is looking at atezo with nab-paclitaxel. There's been some concern that concurrent steroid use with certain chemotherapy agents might interfere then with revving up the immune system with using these PD-L1 and PD-1 inhibitors. So the partnering with nab-paclitaxel in earlier line had a rationale, and there's preclinical data that this combination is better than either agent by itself. But when this was reported out last year at ASCO, it's hard to know if this efficacy is really any different than what we would see with nab-paclitaxel by itself. Right? This isn't a randomized trial. And I guess what's a bit frustrating is that PD-L1 expression didn't necessarily predict for response on the trial. So I think there's a lot to still figure out about immuno-oncology, but it is a very reasonable option given, again, that most of our patients with advanced triple-negative breast cancer are going to have already seen a lot of our traditional best cytotoxic drugs in an early stage setting. And when I approach meeting a woman with TNBC, I first want to know what her BRCA status is. I want to know what her AR status is. And often we'll be looking at tumor genomic profiling in the hopes that that will help me better choose a trial for that woman in the next line setting. So with that, I have a whole bunch of folks to thank that helped me get through the day and have supported me over the years. And I want to thank you. It's a picture of my home office back in New York. So thank you so much for your attention. I'm happy to take questions our last few minutes.